Good evening, everybody. A warm welcome to IAB's online thoracoscopy certification course. As you all know, this is the seventh module. Today is the most important topic, most interesting topic, and we've had the best reviews about today's module already. We're going to be talking about IPC, all that you need to know, and we have the best faculty ever to guide you all through the entire process of IPC. So, as you all know, our thoracoscopy certification course has 10 modules. Those who need the certification, those who want the certification, have to attend at least 8 live webinars, and they need to attend any of the 4 workshops, one out of 4, which will be done in 4 parts of the country, north, south, east, west, in March on 4 different Sundays. So you can attend the date that is convenient, the place that is suitable, and then you'll be getting your certification course. With this brief introduction, I'd like to invite our captain of the ship, our moderator, our boss for today, my very, very dear friend, Dr. Prashant Chajit. Dr. Prashant Chajit requires absolutely no introduction at all. If we talk about Mumbai or Maharashtra, he is absolutely the king of interventional pulmonology. He does more than any of us do. In addition, he is a fantastic clinician, a great academician. He has more number of papers than I can count. With this brief introduction, I'd like to just pass it on to him. Dear Prashant, a warm welcome to you.
Prashant,
Yes.
mute.
Prashant,
Yeah.
can
Prashant,
you hear
can
me
you
now?
unmute yourself, please? Yes. Unmute, please. Yes.
Yeah, I think I've unmuted. Yeah. So, Amita, thank you very much for this introduction, and it's really an honor to moderate this session, which will be where we've got stalwarts here, and also very experienced clinicians, and also experienced teachers here, and also young pulmonologists, who are very important for the country in terms of teaching also, and they're doing a fantastic clinical work. So, Amita, thanks for organizing this, and thanks for the invitation. So now, to start this program, I think the focus today is about IPC, that is the indwelling pleural catheters, and indwelling pleural catheters have been there for almost more than a decade. The importance of indwelling pleural catheters is getting more and more recognized and adapted into practice as time goes on, and particularly its value in the management of malignant pleural effusions, where repeated tappings have to be avoided, where trapped lungs are there, and you can't put in an ICD for a long time, and many more such type of indications are there. So, and particularly an important thing which I find important clinical practice is that you can have an indwelling pleural catheter and you can send patients home. They don't have to be bound to the hospital management, and things can be managed, intermittently at home also, or on a daycare basis. So for this, we have a very experienced panel of speakers, and then subsequently panelists also. So first, would like to invite our dear friend, Dr. Rakesh Chawla. Dr. Rakesh Chawla needs no introduction, a fantastic clinician, speaker, leader, academician, teacher all across, known nationally, internationally. He's on board of our international interventional societies, and also on board of our Indian societies, has held many conferences, our national conferences, our bronchocons, our napcons, and he has contributed in a great way, and he continues to contribute in a great way to the education in pulmonary medicine. In addition to this, he has a yearly conference which he hosts for so many years. So there are so many things which we can keep on talking about him. So for the first lecture, it's my honor, privilege to invite my dear friend, Dr. Rakesh Chawla, who's going to talk to us about indwelling pleural catheters step by step. So, Dr. Chawla, we're looking forward. Everybody's looking forward to hear from you. Over to you.
Yeah. Hello. Thank you.
Yeah, Dr. Chawla, over to you.
Thank you. Thank you very much. Happy Republic Day to all of you. Thanks, IAB. Thanks, Amita. And thank you, Prashant Bhai, to see you intermittently and intermittent. Nice to see you. And we know since you came to India and before you came to India, right? Prashant is one of the best IP man which Amita has chosen for IPC. IPC is a absolutely in infancy in India. What you talk about IPC, you have to talk about the recurrent pleural effusions. They
I'm
are,
sorry, sir. You need to share the slides. We are not seeing it. Sorry.
but this slide came automatically on this, no?
No, no. You have to click the share screen button, sir, on Zoom and then share it, sir.
Okay, 1 minute. Share screen. Okay. Now it is there.
Yes, sir. We can see it. Thank you so much.
Just confirm moving.
Yes.
Yes, sir.
Okay. Okay. So IPC is in infancy in India. As Prashant has already told, it is since 1996-97 in the world, and people are practicing, doing trials, giving their conclusions. But still, Indians in India, because of the financial resource strains, we are still sticking to the pigtails and to the ICDs. And we know the recurrent pleural effusions, where the patient is requiring the multiple thoracocentesis or a more definitive therapeutic modality to prevent the recurrence. IPC is a specially designed small tube which allows fluid to be drained from around the lung easily and painlessly. And there is a valve on the outer end of the tube to prevent fluid leaking out of the tube. Malignant pleural effusions are common, affecting up to 15% of all patients with cancer. And the incidence is likely to rise as global cancer incidence is increasing and overall survival is improving. IPC as a first-line treatment, originally it was a second-line treatment for the trapped and the failed pleural disease in the past. In fact, it is the improvement in dyspnea which occurs in over 90% of patients with IPC placed for malignant pleural effusions, which led to the idea of offering IPC as a first-line alternative to the inpatient pleurodesis. American Association of Bronchology and IP, while the efficacy of IPC for palliation of malignant effusions is supported by robust evidence, but there is less clarity surrounding the post-insertion management. Given the growing evidence supporting IPC, there is increasing interest in combining their use with other pleurodesis procedures. The indication of trapped lung, which is where the lung doesn't oppose, the visceral and the parietal pleura doesn't oppose, and the hemithorax is with the air. This is what we call it as a trapped lung. There is no single best approach to definitely manage recurrent malignant pleural effusion. Two are the most widely used things are chemical pleurodesis with the ICD or the pigtail and the IPC indwelling pleural catheters. BTS guidelines also 2022 talk about the IPC, which is established as one of the major tools for management of recurrent pleural effusions. And majority of the patients are likely to experience symptomatic benefit, are effective at controlling the symptoms for non-expandable lung, cost effective in the longer term, dramatically improves the quality of life in patients who have typically needed lengthy hospital admissions. American Thoracic Society document says the malignant pleural effusions with suspected expandable lung, TAL pleurodesis is the choice, and with non-expandable lung, IPC. This is a document of 2018, but things have changed now. The recommendations are changed. The latest studies have come with IPC with TAL pleurodesis, which is going to change the whole system. Warren et al. Compared IPCs to the chest tubes and chemical pleurodesis, but recurrence in the chest tube chemical pleurodesis had been 13% and higher. But additional advantage of IPCs include a low failure rate, improved quality of life, low initial cost, and a shorter initial admission at a time. The most widely used device worldwide is 15.5 French in dia and 66 centimeters in length is the Pleurex catheter, which was given approval in 1997, which has been widely and the worldwide recognized, forgetting about the Robinson's device, which he did in 1994 for recurrent pleural effusions as a Tankoff catheter. What is this Tankoff catheter? This is same like a tunnel device, but here you are using 15 centimeters of tunneling to access with the tearway catheter, which we are using in our Plurex device also. Famous 5 randomized controlled trials. PGs who are attending can have a screenshot knowing the detailed name of these trials. We know time 1, time 2. If you ask what is time, it is therapeutic intervention in malignant effusions. NVALT is the Dutch Society of Pulmonologists. CAL-GB is cancer and leukemia group B. AMPLE is Australian malignant pleural effusion, which is AMPLE 1 and AMPLE 2 trials. And there are 4 retrospective observation studies and 1 prospective observational study. All of them favor IPC over chemical pleurodesis, which also helps in reduced length of stay in the hospitals. There is a list of these important trials in favor of the IPC, where they have compared with the pleurodesis through the ICD, one with doxycycline, another with talc, another with talc, another with talc, all of them with the talc, with the endpoint of stay in the hospital or the dyspnea score, or the combined outcome of the dyspnea score and the hospital outcome. The time 2 trial, which is a very famous trial, which they have done a slurry pleurodesis via 12 French intercostal drain with a primary outcome measure of patients reported breathlessness over 6 weeks. There was no significant difference in dyspnea score, but small difference in breathlessness favoring IPC at 6 months. IPC was associated with reduced time in the hospital, reduced requirement for further procedures, increased adverse events like cellulitis was recorded. The same things have been observed in the AMPLE study, which has randomized 146 patients with malignant pleural effusions. The complication rate in this study also is higher in IPC group, which they talk of cellulitis, which is 30% versus 18% in ICD. Another systemic review and meta-analysis, they also compared, and it also showed that the shorter hospital length of stay and fewer repeat pleural procedures again carries a higher risk of cellulitis. We are made to understand that IPC is for spontaneous pleurodesis. Success rate in talc arm was uncharacteristically low, while IPC arm it is 62%, even higher. So the crux of these all studies is the length of stay in the hospital, autopleurodesis with the IPC catheter, the helplessness in the breathlessness, and the complication rate of cellulitis is slightly higher. When the patient is on chemotherapy and patient is a malignant pleural effusion, there is a study where 170 chemotherapy patients have been compared, and chances of infection in these pleural infection was equal as with the non-malignant pleural effusions. So there is nothing to worry when the patient is on chemotherapy, whether to do IPC or not to do IPC. And it should not preclude to the use of chemotherapy. But at the same time, you have to take oncologist in confidence to see that is not a phase when the patient is passing through neutropenia or thrombocytopenia, because that is what we will taking as a contraindication. The immunosuppression, because the patients are on immunosuppressive drugs, the persistent long-term drainage and the fluid leads to the significant loss of proteins. And 1 liter of the exudative fluid contains 30 grams of the protein, but there is no significant electrolyte abnormalities in patients with benign recurrent pleural effusions. Future of IPC. When these catheters get blocked, you can use urokinase. Combination of IPC and pleurodesis agents may have the potential to significantly alter the paradigm of malignant pleural effusions management. Why patients should not get the best of both the worlds? The same group has gone down to the drug-eluting IPC, which they created with silver nitrate eluting catheters, but they induce pleurodesis. Still, the things are in the animal studies. Overall cost and cost effectiveness finally remains cheaper. We talk in India about the cost. Think of truly the ICU stay in our corporate hospitals that cost around 30 to 40,000 if patient is not on ventilator. If he is on ventilator, it is crossing a lakh of rupees. And if you are able to give patient who is not on ventilator, only in ICU with recurrent pleural effusion and breathlessness, and you gave him the IPC, think the lease of life, and you saved him from what which is not visible to the patient or to all of us. But we think of the cost of IPC, which is approximately, say, 25,000 rupees, and recurrent cost of the bottle, which Amita was talking. There is no need. You don't have to use that bottle. You use a Euro bag, which has got a one-way valve on the top, and use it, and you can throw it, and you know the cost of the ICD Euro bag, which we are using. I'm doing this IPC since 2014, 2015, and by now we have done more than 175 of IPCs. And I'm going to discuss with you what are the other indications which we have used the IPC. The combination, this IPS plus study, which is recently published, where the IPC with talc has been used, and it is the important advancement in management of malignant pleural effusions. The previous guidelines had recommended IPC as a treatment option only for non-expandable lungs, but now you are to use IPC in recurrent pleural effusions, which is much better than your intercostal drainage tube or the pigtail catheters. Symptom score, the chest pain, there is not much of a difference. Now, who will take care of these indwelling pleural catheters? They have to be self-managed. You have to involve the family, you have to involve the nursing care, create a team who will look after these patients, and if there are any complications, they will report back to the IPC team in the hospital. So you can be ambulatory, and you can make them teach, learn them to how to manage. If there is any complications, what complications can happen, I'm going to discuss with you. So managing malignant pleural effusion with indwelling catheter is an in thing today, and they don't require, if they want an aggressive regime. And early pleurodesis, the studies proved that if you do drainage every day, the pleurodesis is much earlier than the schedule. When he becomes breathless, he will drain the fluid. So this is what I was talking about, the community nursing. And if there is any complication, the support group gets the consultation of the pleural team, and if the problem they are not able to manage, will report back to this. This is the pleural manometry. We did this study in 2016 on this digital pleural manometer device. I'm sure most of you who have logged in have not seen this. So I procured it from USA, and we did on this device the manometry and what it helps. And then we compared it with the manometer system, like you do the CVP pressure monitoring. We were doing the pleural pressure monitoring. And this will automatically record. The battery life is 8 hours in this small gadget, which you are able to see. So when you are removing a 250 ml of the fluid, you keep on making the graph. If there is a gradual decline in the pressure, the patient is going to have an entrapped lung. And if there is sudden fall of the pressures, this patient is going to go for a trapped lung and is an indicator for IPC. But since now things have come up, then we can put in an IPC even in benign and malignant expandable lung conditions. So when you chart a graph after your pleural aspiration, after every 250 ml, you know the condition. And such a wonderful gadget, if you can get hold of, I think is good. And we are doing all this since 2015-16. What are the indications? It's a malignant effusion, primary or metastatic, recurrent benign effusions, chylothorax, loculated effusions, empyema, hemothorax, hepatic hydrothorax, chronic renal failure, which the literature does not discuss. Aditya has joined this panel. I am very fortunate having my son here in the panel. He is the one who has done around 52, 53 chronic renal failure, exudate, hemorrhagic, not responding to dialysis. And we have placed the IPC in these patients, and they have improved so nicely. The life became so comfortable, and we removed the IPC. How we removed, I'm going to discuss with you. Another indication is a failed pleurodesis. trapped lung. Many international guidelines advocate first line of IPC as an alternative to fluorodesis. How we do it? You know now, this is the IPC, this is a tear-away catheter. These are the sites which we will choose. They are now established to be used for recurrent pleural effusions. They may be benign, they may be malignant. You are not able to manage them and they are recurring. You must think of IPC. So the variety of catheters have been used. There are 2 or 3 kinds available. Is a 66 centimeter long, 15.5 French silicone rubber with fenestrations at the anterior end, which goes inside the pleural cavity. And the fluid is drained in the vacuum bottle. The problem in Indian scenario is the cost of this bottle, which we keep on cribbing about. There is no need to buy this bottle, which they peg it at $500 a cost, and it's usable, and you throw this bottle after liter or 2 liters of the drainage of the fluid. We are using Eurobag, which has a one valve on the top of it and does a wonderful job. This is how the IPC kit, since it's a module of the workshop. When you open the kit, these are the things in the kit. You have the tear-away catheter, you have the needle, you have the syringe, you have the IPC catheter with the tunneling device and the connector to this when you are putting it to connecting it to the Eurobag or to the bottle, whatever, and this is the guide wire. How we are going to use them. You must know the basic thing. We have to tunnel. That's why this is a device which is called as a tunneling device. Normally, you do a PAC, consent as in any other procedure. You take all cares what you take during a bronchoscopy. You stop antiplatelet therapy. People even have done these small bore IPCs without stopping clopidogrel, but we will not recommend you using clopidogrel and do the procedure. Newer oral anticoagulant should be stopped 5 days before. Ticagrel 7 days. Rivaroxaban, apixaban, and doxaban tablets should be stopped 48 hours in advance. And enoxaparin and fondaparin should be stopped 24 hours before. So I'm sure moderator will discuss with you. I'm going to discuss with you the technique, whether the tunneling first or the wire first. Length of the track can be adjusted as per the physique of the patient. Local anesthesia you should use with adrenaline or without adrenaline for hemostasis. The IPC removal is very, very important. When the tunneling is done, you have, when we are removing it, a lot of fibrosis happen at the polyester valve, which we retain under the skin. You have to remove these adhesions. There should not be a pulling, excessive force, and you lead to the complications. This is a case of massive pleural effusion, recurrent pleural effusion, where repeated thoracocentesis were required. You can see the X-ray, and you can see this X-ray on a day after. These are the visuals of the CT scan. This is the IPC inside. We did it in local anesthesia, conscious sedation if required. You can use it under the monitoring as we do any other IP procedure. Ultrasound guidance for having the position where we have to put it. Normal is the triangle of safety in lateral decubitus, but because you can choose wherever you are able to drain, there is nothing, no rule like this. Like thoracoscopy, we try to have it in triangle of safety, but wherever there is a fluid, catheter can be placed. You have to keep in mind the area of radiation burns, scars, brass strap level. Ease of access may alter the chosen insertion sites. Second point has to be 5 to 8 or 5 to 10 centimeters. Same rib space anteriorly or inferiorly where the IPC will exit the skin. Same like asepsis, you mark 2 points, then you incise these 2 points with 1 to 2 centimeter incision. You are putting the catheter first to have the pleural fluid drainage. Place the guide wire, and the another side you will be tunneling and pulling the tunneled catheter before you try to put it. This is how I'm sure you are able to see these videos. We are trying to fix up where to do the things. You do the ultrasound, you mark this area, and the second point of exit. Also, you see with the ultrasound, distance has to be around 5 to 10 centimeters. And at the same time, you are able to see it on the monitor, what we are doing and where the marking is done. and there is an effusion. Here you are now prepared after cleaning, after ultrasound, and everything, the marking has been done, and you do a local anesthesia, and you are putting in the local, and after injecting this, you will try to anesthetize the tract, the points which you have selected to place the IPC. Now, the points which have been selected, we will give a 1 centimeter nick, which is enough to place, or 1.5 centimeter as desired. Now, you are going to, normally we use 18 gauge catheter, spinal catheter first, to pass it simply to dilate it through these 2 points. And once we are able to do it and anesthetize it nicely, the first point, now we will put in the catheter and the guide wire. We normally practice the guide wire first, but again, there is a debate. You want to place a guide wire first or you want to tunnel it first. Now, with the tunneling catheter already dilated the tract, we will be pushing this tunneling device on which already IPC is attached. So it is coming out. Already guide wire is there, you can see. And once we have introduced this, the tunneling device is coming out, and this is where you are going to adjust the polyester valve. This is the polyester valve you are able to see. We will keep it 1.5 centimeter into the skin to fix it and feel it. Now we are going to push in a tear away catheter, which we will push it through the area from where the guide wire was coming. It is placed on the guide wire, and we are pushing it inside the pleural cavity. And once we are going to push it, the stellate of this tear away catheter we will take out with the guide wire. Now we are out with the guide wire, and the tear away catheter is ready. Now we are putting the another end of the tube into the tear away catheter. You will see how this tube is going freely inside. Once the maximum portion has gone in, we will gradually start tearing this. It's very soft to tear. There is nothing that you have to put in a great force. You keep on pushing this catheter into the pleural cavity and keep on tearing this catheter. And I think a lot of workshops, Aditya has demonstrated the IPC insertion in the small models, how this tear away catheter is tiered, and you are able to push this catheter into the, now you see the whole IPC catheter has gone in. It's not visible, and it has come out. The another end, we are attaching it to the bottle. After the coming to the bottle, the one-way valve is there, which will avoid the leaking. Now the bottle will be draining. It is again, the beauty of this bottle, it has got a negative suction also. That is all right, but the cost is also very, very important. Now the fluid is being coming. You can lock it once the fluid has been drained, and you lock with that extra valve which is with you. Now you dress it around. After fixing the tube, you can dress this whole system and making the patient ambulatory so that he can be going with this final. You just wrap it on this. This whole dressing also is coming in the kit. It's also in the kit. So we are closing those 2 sutures. Everything is done. IPC is connected. The patient is fully discharged and ready to go home. Before sending, we do the X-ray chest to see the position of the IPC. That is very, very important. And frequency, they can do 3 times a week. As I told you, if you follow the aggressive regime, which should be every day, the incidence of the pleurodesis is higher than 3 times a week when he becomes breathless. Choices of the patient. And with a normal drainage time, which lasts around 15 minutes, he can be told. What prohibits you to put an IPC? Uncorrected coagulopathies, pleural infections with evidence of ongoing sepsis, cutaneous infections, significant malignant involvement over the proposed insertion site, immunosuppressed patient. You have to be careful. Neutropenia or significant thrombocytopenia is a concurrence of the chemotherapy. But as I told you, the studies have done that this is not an hindrance to putting an IPC. What complications? It doesn't come without pinch of salt. IPC or any interventional pulmonology procedure, when you are entering, be ready to face the music at any stage. So early procedure-related complications, then months after placement of catheter-related complications. Procedure-related complications are pneumothorax, subcutaneous emphysema, bleeding, overlying skin infections. Pneumothorax is more commonly seen in the trapped lung. Even subcutaneous emphysema is more when you are doing a thoracoscopy, and post-thoracoscopy, you are trying to place the IPC. The incidence of subcutaneous emphysema is high when simultaneously, after seeing the lung is not expanding, you decide to put an IPC, the incidence of subcutaneous emphysema is high. Catheter-related late complications, cellulitis, the empyema, and this is what is being corrected. There is nothing to worry. There is no need to remove the IPC. The antibiotic therapy does a good job. Sometimes you have to use a TPA or deoxy. DNase is also recommended. The most common organism is Staphylococcal aureus, but people have cultured Pseudomonas aeruginosa and Enterobacteria C. bacteria. IPC-related pleural infections, 11 centers, 1,021 IPCs, and they had an incidence of 4.8% of the pleural infections. As I told you, 94% got successfully treated with the antibiotics as per the antibiotic biograms of the culture reports. The two largest collection of IPC data from the 10 centers saw, and they could see 4.7% to 2.8%. The organism was Staphylococcal aureus, and this is what was the incidence of empyema. Tunnel infections are erythema, tenderness, induration overlying the tunnel tract, catheter tract metastasis, and the seeding. They say the mechanism is when you are putting in your catheter, the pleural pressure of the fluid inside is more that it seeps into either the pericatheter seeping or the seedling into the tract or in the tract itself. That may be the cause. So prior to IPC, if you are able to remove some of the fluid, reduce the intrapleural pressure, that will help you to avoid these complications. You can see the catheter tract metastasis paper, which was published from Sydney by Rajesh Thomas. This is another complication you can see at the insertion site of IPC. Again, the metastasis on the catheter tract itself. Symptomatic loculations. They are not very common, but they have been seen in 14% of patients. And you can use atiplase, or you can use urokinase, you can use streptokinase. In India, both of these things are available. But the bleeding incidents have been there, which has been 3%. Chest pain is frequently encountered, but it resolves with the symptomatic treatment. IPC fibrinolytics, as we have discussed, they help in increasing the drainage, reduce dyspnea, improve the X-ray chest, but 40% recurrence is there. This is the X-ray pre-fibrinolytic, and you can see post-fibrinolytic loculations. You can remove, dissolve. There is no need to remove the IPC. Dislodgement happens in a patient who are on immunosuppressive drugs. They are malnourished. So being virtue of this and cachexia, the tunnel becomes loose. When it becomes loose, the catheter can dislodge. You must tie at both the sides very nicely with the stitch, and you can take this also catheter into the loop of your suturing so that dislodgement does not happen. Blockage, catheter blockage, people have even recommended in empymas, but the problem is of the fibrinous material. It's uncommon in other conditions, but still happens. You can use, as I have told, the drugs like atiplase, you can use urokinase, you can use even streptokinase as to relieve these blockage. You can see how cellulitis happens around, how the fibrinous material is removed, which plugs, and how the catheter dislodgement happens. And I've told you, pericatheter leakage or the seedlings or the tract metastasis, all mechanisms are same because the fluid can seep into this. This is what is very, very important. The catheter fracture. If you are a little careless in removing the way we are tuned to remove the ICDs, we cannot play with this catheter. You have to dislodge that the polyester plug inside because that is fibrogenic. to remove that, and whole track you have to remove the fibrous tissues, and then only you remove, if by chance fragments are left behind of the IPC, no issues. People have done studies on that. Leave it as such, and you can go with the paper of Faish et, who has shown these fracture indwelling pleural catheters and how to manage them. So it's a very, you have to be very safe when you are removing the IPC. So again, it is an art. The fractured pleural catheter, another case, you can see how when aggressively you try to pull out and it gets fractured. So polyester cuff and its handling is very, very important. This is another paper where they have shown the complications in malignant pleural effusion and benign pleural effusions. Another newer complications are reported in the literature where this polyester plug is retained under the skin. No worries, you are able to retrieve this, and the polyester plug is missing. No worries, let it be there. No need to try to meddle with this, or the catheter inside gets blocked with the malignant material. They have compared it with this plant called Corallorhiza trifida. Complications and their managements I have addressed simultaneously. Another population of hematological malignancies and solid organ transplant has to be taken care when you are putting it. Aftercare is very, very important because the patient is going to be lifetime with you. You have to involve the patient, community, family, and see the funding of the drainage kits. These things are not practiced in West. They want the bottle which is there, which is expensive. So the regular follow-up, management of complications, IPC removal when it needed, and may require management of other things. When you are planning for an IPC, very, very important, in Indian scenario for medical litigation, you must sit with the family, with the patient, and answer, because a long-term indwelling program. So you have to address to the patient in your conversation, what is an indwelling pleural catheter? How is the indwelling pleural catheter put in my chest? Who will drain the fluid? How often I drain the fluid? Why do I need an IPC? Are there any alternatives? What happens during IPC? What happens after the procedure? What are the risks? Can IPC be removed? Effect of sedation? Post-IPC chest pain? What can be done to help me when fluid collects? Are there any risks? Is there anything I need to do? How does the drain stay in position? Can I wash and shower normally? Yes, these patients can swim normally in spite after 3 or 4 weeks when things have already settled. So take home messages. There is a good quality evidence of IPC, which is in infancy. I'm sure after this webinar, a lot of pulmonologists will be convinced and confident to do, because it's not a difficult procedure. It is not an expensive procedure. IPC have now become a mainstay of recurrent effusions, consistently low rate of complications, reduced inpatient stay, significant improvement in patient symptoms. They are relatively easy to insert, manage, and remove. As use of IPC is becoming widespread, most of the physicians will possibly be facing the complications, which you must know how to address. Indwelling catheters are very well tolerated. Patients with mesothelioma, this is where the chances are of the tunneling infection or the metastasis or the tract metastasis. Indwelling pleural catheters are designed to remain in position permanently. Catheters can be removed as a day care procedure. So it's a day care procedure, placement even, and the removal. Thank you very much. IAB and ICS announces we are going to do a survey of IPC practices in India. So soon you will be getting link on your mails and on your WhatsApp. So please participate with full support. Thank you.
Great, sir. Thank you so much, Rakesh, for this excellent overview. In the true sense, it was a step-by-step approach as far as the IPC catheter is concerned. From the description of the procedure to all the clinical issues that one may come across. Now, after this such an extensive and a lucid explanation of the IPC, we move on to the next lecture. And the next lecture is also from our dear friend, Colonel Dr. Professor Vikas Marwa, who is currently at the 150 General Hospital, Rajouri at the Pakistan border. Dr. Marwa is a very good clinician, a very good researcher, and also a very good teacher. He's received several military awards. He has received the prestigious Sena Medal, which is the Sena Medal Presidential Award in 2022. He's received the Kalinga Trophy at the AFMC. He has also received the Chief of Army Staff Commendation in 2014. He's received the Best Presentation at the Yorkshire Thoracic Society in the UK in 2017. And he has more than 96 publications to his credit. And along with all this, he continues to do teaching on a regular basis and is a very good teacher. So, Vikas, over to you for the next talk, which is a very important talk. After Dr. Chawla has taken us through this step of the IPC step by step, Dr. Marwa will speak to us about the current scope of indwelling pleural catheters and the Indian experience, which is going to be very relevant, a very good topic. Over to you, Dr. Marwa.
Very good evening to all of you. Thank you, Prashant, for a wonderful introduction. Very happy Republic Day to all of you, and it's a great honor. It's a very great day to connect for an army person on Republic Day, and that too from the Pakistan border, because I'm just 10 kilometers. Rajouri is 10 kilometers from Pakistan. So over the next 20 minutes or so, I would be speaking about the current scope of the indwelling pleural catheter and the Indian experience. So this would be the outline of my presentation. So I'll be discussing the IPC in management of malignant pleural effusion, followed by role in non-malignant effusions, indications and contraindications, which have partly been discussed, and my job has been made easy by my predecessor. The protocol for IPC removal, I'll be spending some time here, and the Indian experience, followed by a bit on complications, and then I'll summarize. So what's the scope of IPC in malignant pleural effusions currently? As you can see, the management of malignant pleural effusion essentially is palliative, because this portends a very poor prognosis, and usually the survival is few months, 3 to 12 months, depending upon the underlying malignancy and the response to the chemotherapy and the EGFR status. So if the life expectancy, which we find out by the Lent score, which we do in these patients, is less than 1 month, then usually outpatient based aspiration therapeutic tap is good enough. But if they have got better prognosis, then we have to decide between a chest tube with pleurodesis versus a home-based ambulatory management, which is now available in the form of IPC, plus minus the pleurodesis. So the patients who have a non-expandable lung, the IPC is preferred, as has already been discussed. But when the patient has a expandable lung, and then you have to offer the choice of IPC or chest tube with pleurodesis to the patient, and discuss the cost, the availability, the follow-up, and there are a lot of issues which I'll be discussing over the next few minutes. So coming to the evidence which we have, the ample randomized trial which was published in 2017, and this basically looked at the improvement in duration of hospitalization, and this was a randomized controlled trial of 146 patients which either received an indwelling pleural catheter or a talc pleurodesis, with the primary endpoint being total number of days spent in hospital from procedure to death or to 12 months, and the secondary outcome being further pleural interventions, quality of life, and adverse events. So this was basically 1:1 randomization to look at the benefits. And what it found, that the treatment with IPC resulted in fewer hospitalization days. As you can see here, 1 versus 4 days in hospital for the procedure for talc pleurodesis. And essentially these were effusion related hospital stays. The overall state did not improve significantly, because these patients, cancer patients, advanced cancer patients, have got other issues as well, which need to be managed, especially the progression of the disease and for chemotherapy and the complications. It also significantly reduced, as you can see, the ipsilateral further invasive pleural procedure requirement in these patients. So it is, you have done a procedure and the patient goes home, and usually you not need to repeat a procedure, which many a times you have to do for a failed pleurodesis. So after the reduction in hospitalization, they looked at the improvement in dyspnea, which is the time 2 trial, which is a unblinded randomized controlled trial done at 7 UK centers. They had 106 patients with malignant pleural effusion, which were randomized 1:1 to either IPC or chest tube with talc pleurodesis, and they looked at the improvement in dyspnea by the VAS score or the visual analog score, 0 being no dyspnea and 100 mm being maximum dyspnea. So what they found out in terms of improvement in dyspnea is that initially in both the groups, there was no significant difference in the first 6 weeks. But when they followed these patients up at 6 months, they had significant improvement in dyspnea in the IPC group as compared to the chest drain and the pleurodesis group. And it was -14. Difference was around 14 in these patients. This is essentially because a lot of patients with pleural disease, they develop recurrent, effusions and collections, which are possibly the cause of this worsening dyspnea. And they also found out that the length of initial hospitalization was significantly shorter in the IPC group compared to the chest drain pleural disease group. However, there was no significant improvement in the quality of life. So they found that there is significant improvement in dyspnea and reduction in hospitalization with these trials. What is the impact on quality of life? Because what you're looking at in these patients is that you cannot improve the survival, but you can palliate them, reduce their dyspnea, which is the most common symptom, and probably improve the quality of life with that. So this was a multi-centered trial from Canada, which was published in Respiration in 2011, which looked at the impact of tunnel pleural catheters on the quality of life with malignant pleural effusions, and it involved 81 patients post IPC insertion. So they found that 2 weeks post insertion of IPC, there was significant improvement in the quality of life and dyspnea score in these patients. So we have the recent BTS 2023 guidelines, the pleural disease guidelines, which has been published by Roberts and Thorax. So they compared the two and they found that in terms of the IPC, the length of hospital stay was significantly less, and it was much longer for the patient who had to stay inpatient with talc slurry. And the patients with talc slurry required repeat pleural interventions, approximately 3 to 4 times more than the patients who had an IPC. So the IPC scored better compared to ICD pleurosis in these two parameters, namely the hospital stay and the need for reintervention. And in terms of complication, there was not much difference, and the symptoms also and quality of life, there was not much different in the two arms in these guidelines. Coming to the modification. So if you have a modified IPC with a silver nitrate coating, is it better? So the SWIFT trial looked at it. So this was published last year in a multi-center randomized trial of 114 patients comparing silver nitrate coated IPC to the uncoated IPC, and there was no significant difference in the rate of pleural disease between the two. So having additional silver nitrate adding to the cost did not lead to better outcomes in these patients. So now what is the scope? So we have all been using IPC in basically malignant pleural effusions, but there's a large volume of data which looks at the role of IPC in benign effusions. And this was a meta-analysis published in Chest in 2017 of 13 studies with total of 325 patients. And the commonest subgroup was that of the congestive heart failure. And these patients, the spontaneous pleural disease was achieved in 51.3% of the patients. And the major complications were empyema in less than 3%, loculation and dislodgement in this. So it was found that IPC is an effective and viable option even in the management of refractory benign pleural effusions and not only malignant effusions. This was another study. As you can see, one of the most common indications which is widely been published is congestive heart failure related recurrent pleural effusion, followed by the hepatic hydrothorax. So a lot of these patients are on palliation or they are waiting for liver transplant and they develop recurrent effusions which are troublesome, requiring repeated hospitalization. So 79 of these patients were enrolled. 21 of them were basically it was a bridge to liver transplant, and the median in situ time was 156 days. So you see that the longer duration is required in benign conditions compared to malignancy because of the better survival probably. And the pleurosis was achieved in 28% of these patients, but they had around 10% of them had pleural space infection. So these patients have reduced immunity. So compared to malignant pleural effusion, the infection rate is higher and probably the pleurosis time is also longer in these patients. So what is the role of tunnel catheters in patients with chylothorax? Many of these patients, with chylothorax, they are refractory. You have tried everything, all medical management, and still it persists. So IPC has been trialed in these patients, and autopleurodesis was achieved in good 9 out of 14 patients in this study, which was published in 2013 by Depew et al. And the median time was 176 days in this patient. And there were no adverse nutritional, hemodynamic, or immunological outcomes. So they concluded that IPC for management of recurrent pleural effusions in chylothorax should be considered early, and it can be a safe and very effective modality in these patients. So this was another study published in Chest which looked at the IPC for cardiogenic pleural effusions, and they found significant improvement in dyspnea like we get in malignant pleural effusions, and the spontaneous pleurosis occurred in 29% of these patients. So it is a feasible option, though it is not the first line option. You basically do the medical management of the patient, optimize the heart failure management. If still it is persistent, you do a therapeutic tap. If the patient is improving and comes back with a recurrent pleural effusion, then possibly you can think of IPC, but definitely it's not the first line management. So how do we decide whether the patient is going to benefit with the indwelling pleural catheter? So firstly, the patient should either have malignant pleural effusion or benign effusion. with or without a non-expandable lung. Essentially, non-expandable lung can have underlying endobronchial obstruction or a pleural entrapment in these patients. So you have to firstly try a volume pleurodesis to basically see if they get symptomatic benefit. If they do not improve symptomatically, then possibly the cause is different and it is not going to get better with the placement of IPC. So this trial of a single large volume thoracocentesis of 1 to 1.5 liters is a must. And then if the patient comes back to you with rapid recombination within a month, then possibly he's a candidate and he has got recurrent pleural effusion. So those patients who have got a shorter survival, which can be judged by the Lent score. Lent score is essentially the pleural fluid LDH, the NL ratio, which we've all been doing in the COVID times on the CBC. The E is for ECOG score and T is the tumor type, and you can calculate it. There are a lot of calculators available online. So survival is very important to be decided in these patients to decide what modality should be offered. If the survival is very poor, possibly 2 weeks, then they're not going to benefit from your Plurex. And these patients, therapeutic tap may be good enough. If it recurs, then possibly you can think of another option. So if somebody has got more than 2 months survival, then probably you can look at pleurodesis because the collagen laying time itself is 6 to 8 weeks. So the patients who have failed pleurodesis or do not prefer a repeat pleurodesis, so they are the patients whom you can offer a IPC. So essentially, initially we started doing it for trap lung and failed pleurodesis subgroup. Now we have moved on to even the expandable lung, where the patient does not want to be hospitalized because these patients have got very poor survival. And if you admit any patient who has got a 4-week survival, if you admit him for 7 days, it would be 25% of his lifespan. The contraindications have been covered: coagulopathy, ongoing infection, cutaneous infection. A very important thing in our, Indian, most of these studies come from West, where they have got very good community healthcare setup. You've got district nurses, people who go home and drain. But in India, if somebody, doesn't have a good family and a social support, and if they're illiterate, they're not able to understand how to perform the drainage at home. Possibly then you should go back to the ICD with a pleurodesis rather than a Pleurex catheter. So you need to have a motivated family and a good support who can do this. Now, coming to the important part of my talk, that because that is what has changed over the years is the drainage protocols. So it has been briefly been touched by Dr. Chawla, sir. So there are two protocols. One is the aggressive fluid drainage, in which you do a daily drainage. So what this does is that this leads the lung to expand and provides maximum relief in dyspnea. And also early pleurodesis is seen, autopleurodesis is seen in these patients. But it comes at a cost because you require more bottles and you require more disposable. The symptom guided drainage is a drainage of fluid in the absence of breathlessness. But it has been shown that symptom guided basically when the patient has breathlessness at home. But it has been shown, that in the absence of dyspnea, the drainage does not improve the quality of life. So these patients, the consumable cost is much less because less number of bottles is required, and there is more time at home in these patients rather than they for coming repeatedly for medical attention. So the two important trials which looked at the drainage criteria is the ASAP trial and this is oscillation trial. And what they did was they randomized these patients to aggressive or a daily drainage versus in 76 patients they had a alternate day or a thrice a week drainage. What they found that the rate of pleurodesis in the aggressive drainage group was approximately twice that in the standard drainage. So if you drain daily, the lung comes up faster, there is more apposition, and the autopleurodesis takes place. And also the median time to autopleurodesis is shorter in the aggressive drainage group. So they found that if a patient wants a faster liberation, you should do aggressive. You need more bottles in these patients. So cost is going up. Another trial which was the AMPLE-2 trial, which looked at 1:1 randomization, which was aggressive versus a symptom guided fluid drainage through an IBC at home. So in this, the dyspnea did not improve much, but they found that in the aggressive group, like the ASAP trial, the spontaneous pleurodesis was much more. So both of these trials showed that if the drainage criteria is aggressive, then possibly you'll get faster liberation and early pleurodesis. So if you look at the BTS guideline between the two drainage criteria in the length of stay, as such these patients are not hospitalized, so there's no difference. The pleurodesis rate is lower with a symptom based or a conservative drainage. But the quality of life is reduced with a symptom-based drainage because these patients continue to have this catheter for long if they do not have a pleurodesis. So the guideline which recommends is that where you have to have early liberation, where IPC removal is a priority of the patient, so daily IPC drainage is recommended at home. And patient should be advised that, the daily drainage does not improve their quality of life, even though it may improve the dyspnea in these patients. Now, coming to early liberation, since we're talking about the drainage, so this was a very important trial, the IPC Plus trial, which was published in the NEGM in 2018, which essentially looked at a indwelling pleural catheter with a pleurodiscs with talc versus a placebo, which was a saline, and it was a multi-center trial over 4 years, which was done in the UK, where they instilled 4 gram of talc in the IPC on day 10. So if the patient continued to have drainage, they had 2 arms. At day 10, they randomized 1:1, either to receive talc pleurodiscs or these patients had, placebo, which was a saline. And the primary outcome was pleurodiscs at day 35 after randomization. So 5 weeks after the installation of talc, and they were followed up for around 70 days. So what they found that the patients who had talc installations, 43% of these patients had pleurodiscs compared to 23% in the placebo group at 35 days post randomization. So as you can see here, after 5 weeks, almost double the percentage patients with talc had pleurodiscs, and so it was a early removal of catheter compared to these who continued to drain for a long period of time. And also this benefit continued to accrue even at 70 weeks, where approximately 51% with talc had pleurodiscs. So it is time dependent. Longer you follow up these patients, the pleurodiscs chances are more. So the liberation of the Plurex catheter is much faster if you do a pleurodiscs in these patients, but it definitely adds to the cost. Coming to the second part of my talk would be the Indian IPC experience. So I know that most of us have been doing IPCs, but we are very poor at documenting in our country. So there is not much evidence from the country. So this was the first study which we published. We actually started it pre-COVID, so there was a problem in recruitment during the COVID. So we published it in the Lung India in August 22, and it was a retrospective study with all its lacunae of 6 patients, which basically had a moderate to high risk as per Lent score. But these are the patients who benefit the most from the Plurex catheter with the mean age of 59 years, and 50% were lung cancer. So lung cancer portends as such a poorer prognosis compared to breast metastasis or the ovarian cancer, which metastasizes leading to malignant pleural effusion. 5 had unilateral effusion, 1 had trapped lung, and they were followed up for 3 months. So we also looked at the breathlessness improvement with the VAS score, 0 being minimum and 100 being maximum dyspnea. So there was significant improvement like the ample trial of, with IPC in our context, and spontaneous pleurodiscs occurred in 2 out of 6. So that is around 33% of our patients. And median duration of catheter drainage was 60 days. So we concluded that there was significant improvement in dyspnea post-catheter, which was maintained over the period of time. So this was published with the editorial, and it raised very important and very pertinent points. Because we in India, we cannot just follow the West, because cost is always an issue, because ours is not a developed country, and cost, and especially the home care, which I was mentioned in West, they've got very good community and, a community-based and hospital-based health workers who provide support to these patients. So what we need is more data regarding, the cost in India, and that is what the Dr. Dharmesh Patel, who written the editorial, mentioned. And also we need well-planned randomized control trials in a country. So, looking to reduce cost further, we also did a trial, which is presently in the publication, where we changed the drainage criteria. So compared to the aggressive, where we have the benefit of early pleurodiscs, and the conservative, where you have to, spend a longer time, the liberation is much later and more cost because of the requirement of bottles. So we did a hybrid kind of a drainage protocol, where in the first 1 week, we did a high intensity drainage on an OPD basis. And after the fluid was drained, a 5-minute suction pump at low pressure up to -10 was also applied to these patients. Usually these patients as such are, during the early part of malignancy, visit the oncologist for the other investigations, PET scan and workup for chemotherapy. So we utilize this, window to offer them a suction-based drainage compared to a bottle-based drainage with the patent valve which is provided with it, the drainage set. And this also helps during the first 1 week to educate the patient and his relatives regarding the maintenance at home and the drainage at home, which they have to do. And then this was, after 1 week, this was followed up with a symptom-guided home drainage using a vacuum-sealed bottles in these patients. So the criteria for removal is normally in a Plurex, if the drainage is less than 50 ml for 3 days and the X-ray has shown that the effusion has reduced, so then possibly these are the criteria for removal. Because somebody is asking about the removal criteria in the inbox, so I thought I'll answer it here. But what we followed is, because you can't, always call these patients back so early. So the patient comes back to you after 2 weeks, and we do a chest X-ray. If there is no drainage, and if there is no or minimal effusion, we send him back and another, observe him for another 2 weeks. If the repeat X-ray after 2 weeks also fine, then we remove the IPC. So this was our experience. So more than 50%, approximately 52% of the patient developed autopleurodesis, which is much higher even with the IPC TAL group, where there was 47% in the IPC plus trial. So this is probably because of aggressive initial drainage and application of suction in these patients in the first 1 week. So which is a cost-effective method because the cost of the bottles is not there. So 44% still had IPC. Only one patient we had to remove. He was a hepatic hydrothorax patient who developed empyema where the catheter had to be removed. And the time to pleurodesis was also much faster. Out of these 13 patients who had autopleurodesis, 10 had pleurodesis by day 35, so which is quite early. And 10 patients did not have to use any vacuum sealed bottle. So, these patients just had a Plurex and a drainage in hospital, and no vacuum bottle was required in these. And a vast improvement in breathlessness was significant and maintained during the duration of the study. This is the use of bottles which was consumed. As you can see, most of the patients did not require any bottle. And the average requirement of bottle for self-traces was 2.6 per patient. And the mean duration of IPC being C2 in the patients who did not have pleurodesis was 44 days in these patients. So apart from our experience, there's a nice review article anyone of you wants to go through, which was published in 2022 from Apollo Chennai by Dr. Ravindran in the Journal of Association of Pulmonologists of Tamil Nadu. So this is the experience we have. A bit about the complications. It has been covered in detail by overview. Pleural infections 4.8%. You may not always need to remove the catheter. Antibiotics does the job in most of these patients. A catheter tract metastasis can be seen more commonly in mesothelioma, and it can be managed with external beam radiotherapy without the need again to remove the IPC. Loculations we can see in 5 to 14% of these patients, 1 in 6, and usually develops after prolonged drainage of 2 months. And it is also managed easily with intrapleural fibrinolytic therapy with any of the agents as discussed. So there's not much data about the nutrition and cell loss in these patients, but it can possibly cause nutrient loss, but we need more studies for that. One has to be very careful at the time of removal because the cuff which you have polyester, it incites fibrosis. So what we do is we nicely dissect it with the artery forceps. After giving local anesthetic, it has to be nicely dissected so the granulation tissue, the entire catheter is clear of the granulation tissue, and then we pull it out, and it should not be a tug, it should be gently removed. So it's a bit different from the removal of ICT in these patients. And removal of catheter is slightly more complicated than introduction. Introduction is much easier compared to this. Catheter blockage, which we see in less than 5% of these patients, it improves most of the time with saline flush. So to summarize my talk, so now, in the management of malignant pleural effusion pathway, we have an ambulatory pathway management. So if the patient fluid is amenable to intervention, then we have to consider if the lung is re-expandable or not. If it is not re-expandable or it's a trapped lung, then we go directly to IPC. If it is expandable lung, then you do a therapeutic aspiration. If it recurs and the patient comes back to you, then there are two pathways. One is the ambulatory pathway with IPC, and if you want early liberation, TAL can be added. And the other pathway is the older pathway of chest drain with a slurry pleurodesis, which leads to a certain amount of hospitalization and cost upfront. So to summarize, IPC is very effective in reducing dyspnea and duration of hospitalization. It has a role in non-malignant pleural effusion as well, but data is not there from our country as of now. So as I've mentioned, we need more studies and more network trials probably, and faster autopleurodesis with the aggressive draining protocol. And if you want to reduce the cost, then probably you can go for the hybrid approach, which we followed, which was the initial aggressive followed by a symptom-based drainage at home. And IPC is safe with minimal complications, and they can be managed well. It has been well said that we cannot change the outcome, but we can affect the journey. So these patients who need palliation, even though it does not improve the survival, but we can definitely make a difference in making their life more comfortable. Thank you.
So great. Thanks a lot, Vikas, for this excellent overview from the practical aspects, the trials, what the trials have shown, what the Indian approach is, and what you guys have been practicing and publishing. So I think this has been a fantastic, lectures taken by Dr. Chawla and Dr. Marwa. Now we move on to the next bit of our presentation of our meeting today. I would like to invite the panelists for the meetings, and then we'll go ahead with the question answer session. We have already collated some questions, and from based on the feedback received from various people, and plus there will be some questions in the chat box which will also be taken. So in the panel, I would warmly like to invite Dr. Dennis Davis, who's a professor and head of pulmonary medicine and vice principal at the Institute of Medical Science, Thrissur, Kerala. He has a lot of interest in pulmonary interventions and in critical care. He has more than 50 publications to his credit in international and national journals, and received several awards. It's a very impressive CV. And amongst those awards, there are some awards received by the University of Calicut. He received the Young Scientist Award. He received the Young Pulmonologist Award, and he's received several awards at NAPCON and at the Gulf Thoracic Society. Next, I would like to invite Aditya, Dr. Aditya Chawla, who is a very young and a dynamic chest physician, a very good clinician, and very actively and involved in organizing meetings and academic activities, has a lot of energy and a lot of skill to organize things meticulously. He's a consultant interventional pulmonologist at the Department of Pulmonary Medicine, Critical Care and Sleep Disorders at the Saroj Super Specialty Hospital and the Jaipur Golden Hospital in New Delhi. And he's a member of various national societies such as the NCCP, the ERS, the Indian Critical Care Society, the IAB, the Indian Chest Society, and he's been the organizing secretary of Respicon India and has been involved in several conferences where he has been very active in organizing these meetings. And he's also interested in his teaching activity. The third panelist who would like to invite on panel is Dr. Anshu Punjabi. She's the assistant professor at the Department of Pulmonary Medicine at the Tata Memorial Hospital in Mumbai. So the Department of Tata of Pulmonary Medicine is a very active department. Does a lot of thoracic oncology. She's done her MD and DNB in pulmonary medicine. She's done her MRCP. She's got the European Diploma in Adult Respiratory Medicine. She has been a fellow in respiratory medicine at the Norfolk and the Norwich University in the UK. She's got a fellowship in the interventional pulmonology and thoracic oncology at the Wythenshawe Hospital in the UK. So, a warm welcome to all the panelists for today's panel discussion. And with this, I would like to now start the panel discussion. I would like to ask Rennis. Rennis, what are he's been practicing interventional pulmonology. He's very interested in interventional pulmonology. We've got a fantastic panel here. Rennis, what are the common indications for indwelling pleural catheters in clinical practice?
Yeah, thank you, Dr. Prashant. It's a brilliant question. First of all, we have to know the indications when to put in and when not to put in. And the IPC for me is basically for two indications. The malignant pleural effusions, maybe primary from the lung or from any other secondary site. And the second one will be any symptomatic pleural effusion. You call it transrate or exrate. If the patient is symptomatic, I would go ahead with the IPC. They are broad, indications, but still very much valid. That's my take.
So can you expand a little bit upon the indications where you said about transudative effusions, please?
Yeah, what I mean is on non-malignant, what I do is the benign effusions, which were sometimes in cardiac failure and sometimes in hepatic hydrothorax, in a few of the CKD patients, where the fluid drainage will give them the symptomatic benefit. Maybe CKD5, maybe the cardiopulmonary edema with the effusion, which may give once you drain off the fluid, which gives the symptomatic relief. So yeah.
Yeah, great. So Dennis, this is a very important perspective, and this needs a lot of clinical, based on a lot of clinical experience. Varied people have varied experiences, and we'll discuss this as we go ahead further on. Anshu, you're there? Yeah, Anshu, what are the so as Rennis has expanded on the common indications, malignant pleural effusion is an indication which is, it's quite obvious. He also referred to indications for transudative effusions. We will expand on that a bit later on. But before that, can you just summarize the contraindications for the IPC? Anshu?
Good evening, everyone. So I think Dr. Marwa and Dr. Chawla have already covered this very extensively in their talks. So contraindications for IPC will be the same contraindications that you have for any pleural procedures. First of all, that there is uncorrected coagulopathy or severely immunocompromised patients. But two other important contraindications. One is you have to examine the site of insertion for the IPC, because as we have seen from the procedure, you have two ports of entry, one where the catheter will enter inside the pleural cavity, followed by a tunnel, and then it exits out. So that whole area has to actually be free of any local infection, and there should not be any evidence of local infiltration of the malignancy as well in that area. We sometimes do see that the pleural tumors can sometimes also invade the subcute and the skin overlying it. The other more important thing which we have to take in our country is the cost of the IPC, also the recurring cost of the bottles, and patients should have adequate support and at home or in the community. The whole purpose of IPC is lost if the patient has to coming to the hospital every week, 3 times a week to have it drained using different modifications to it. The whole point of putting an IPC is to enable them to have home drainage and empower them to manage their disease properly. So having an adequate home and social support, and we do need to look into community support as well for these patients.
So I think this is very well put in. I think the skin related, the insertion site related contraindications, I think these are very important. And want to just expand a little bit more on the social aspects. I think the understanding of the indwelling pleural catheter has to be understood by the patient, and if not by the patient completely, I think the caretakers have to understand it. They need to understand that care needs to be taken. They need to understand that sometimes patients are not able to follow up. They're coming from a distance, and the challenges I have faced are when patients are from a distance away. You place a catheter, and then there's a lack of local support. And then and then when the fluid needs to be drained, if there are problems in draining the fluid, and if there's no proper attention, somebody who can provide locally, particularly for patients who cannot follow up once the catheter has been put up, I think that becomes a relative contraindication. And I think in my practice, because we've come across patients, getting certain complications which could potentially be avoided. So the learning point here is, I think we really need to understand that, yes, there may be an indication, it may be feasible to do it. The question is it possible to take care of the indwelling pleural catheter? So I think this is just to expand on what Anshu has said. Now let's move on. We've discussed the indications, the contraindications. What are the anesthetic considerations for insertion of IPC? Aditya, can you please just expand a little bit on that, please?
Sir, in personal experience, we are not using much of anesthesia. We are just using local anesthesia on the entry site and the exit site and the tunnel which we make. Then there comes a subset of the patients which are apprehensive or who want to get an anesthesia. So in these kind of patients, regional anesthesia can play an adjunctive role, or use of ultra short acting sedatives and medication can also be used, like midazolam or dexmedetomidine.
Okay, so that's what you're using. So I agree with you. For most of the patients, it is typically done under very good local anesthesia. I think all that we need to do is to infiltrate the local anesthesia very well. And yes, some patients are anxious, and we know that midazolam can give some amnesia, etc. And then I have used also opioids in selected patients, like a fentanyl, which also helps them to reduce the pain or any other pain. I mean, we start using just intravenous paracetamol given just before the procedure if somebody is in aches and pains, not necessarily because so these patients can have a lot of aches and pains. So I think the message is very clear, typically done under local anesthesia. As Dr. Chawla mentioned earlier, it can be done on a daycare basis. And if required, you can give a little bit of a pain relief medication. It could be a parenteral pain relief. It can little bit of sedation to allay the anxiety. And typically, the procedures can be done under this sort of anesthesia. So now that we've discussed the anesthesia indications, contraindications, now the question that often comes up is the IPC over intercostal drainage tube. I think that has already been alluded to in the discussions, but I think it's really important to have a discussion and different views. So I would like to ask Renis, when would you prefer? I mean, for a pleural effusion, we know that you can put an intercostal drainage tube, you can put an IPC. When would you prefer an IPC over a intercostal drainage tube? And what advantages does IPC offer over an intercostal drainage tube? I know this has been already covered, but it would be useful to have your views on it and a summary from your side.
Yeah, thank you. Yeah. Basically, I look into the performance scale of the patient if it's a malignant pleural effusion, and if ICD seems to be an cumbersome procedure for that individual, I would prefer IPC or indwelling catheters. And later on, it will all depend on whether it's expandable lung or how much percentage is expandable, not expandable. All matters may fit in, but in our scenario, Indian scenario, what I feel is if you are doing it as a palliative procedure, better I depend on IPCs rather than going for an ICD, and at the end of life you are giving an extra operative procedure to the patient. I would deny it. I would prefer only IPC in those kinds of patients who are under palliative care, and if you feel like the lung is collapsed and there is tamponade, and then you need a better drainage all of a sudden for the fluid or as well as for the air, then I may prefer only ICD. That's my take.
That's perfect. I think this is a very good overview, and I agree to it. And as I said, there's one more thing, from my experiences and the challenges that I have faced in patients managing who are distal, who may not have care. So in certain patients, I have sometimes prefer to put a small bore catheter, make sure it's functional, that is a intercostal drainage tube, just because that, it may be possible to be taken care at a local level. Because, for patients who are coming from a distance, who may not be able to follow up, I think the local surgeons are able to take care of the intercostal drainage tube better than the indwelling pleural catheters. But again, we need to look at all the aspects. We've had situations where, people have tried to flush in and out of the, the valve mechanisms and all by local doctors. Of course, the intention is good, but I think, if the understanding is not clear, it can lead to problems. So I think that's also very well covered. Also was covered well in the lectures about ICD versus indwelling pleural catheters, and as well was also alluded by the editorial by Dharmesh that we need some good randomized trials locally in our country. Now, one point which Dennis, you also mentioned about the utility of the indwelling pleural catheter in non-malignant pleural effusions. I would like to now ask Anshu for her experience and her view and opinion about what is the data on the use of IPC in non-malignant pleural effusions like hydrothorax, and if you can also allude to your views in transudative pleural effusions.
So in the last few years, we have much more evidence about benign refractory pleural effusions with the utility of IPC. There has been a recent randomized control trial as well done, the REDUCE trial, which compared the patient-related outcomes in patients who were put on IPC for refractory effusions versus therapeutic thoracocentesis. The patient-related outcomes are not significantly different. What BTS recommends is that if you have a patient of refractory benign pleural effusion where all medical management has been exhausted and the patient is needing more than 2 or 3 aspirations for symptom control, you should proceed or consider for IPC. Now, when we compare all the different subsets of benign pleural effusions, I should not say surprisingly, but the hepatic hydrothorax group has found to have the highest incidence of pleural infections. Now, this could be because of probably the suppressed immunity in liver patients, cirrhotic patients, they are also having higher chance of spontaneous bacterial peritonitis, which can also spread to the pleura, and the fact that their white cells are always on the lower side. They are also have hypoproteinemia and all other risk factors. And in this group, in some case reports, the infection levels has been as high as up to 15 to 20% as well. So we have to be very careful in this subset of patients, especially with benign hepatic hydrothorax, and especially when you're considering it in bridge to transplantation, because if these patients develop a pleural infection, they would effectively be taken away from the transplant list also, because if they have developed sepsis. So yes, if they are not for transplantation and you have exhausted all other modalities, please go ahead. And it has to be on a case-to-case basis. It's not a blanket recommendation like what we follow for malignant pleural effusions. It has to be only when all modalities are exhausted. Another indication could be that your patients are sometimes on anticoagulations, like for cardiac patients or even liver patients, they have uncorrectable coagulopathy. So repeated pleural aspirations can be difficult because you have to again correct the coagulopathy or stop the antiplatelets or anticoagulants. So that is also a subgroup where IPC can be considered. They would need much more closer monitoring to monitor for pleural infections.
So I think this is very well summarized. Where in basically whenever what I understand and the takeaway I would take away from this is that in non-malignant pleural effusion, you need to go on a case-by-case basis, and you need to weigh the pros and cons about of the indwelling pleural catheter. And in selected cases, as also was alluded by Dennis, I think there can be a benefit of using indwelling pleural catheters. So I think that's also very well explained. Let's get a little bit more on the technical aspects also. Aditya, I would like to ask you, what pitfalls can you expect while inserting the IPC? Are there any precautions that need to be taken to avoid any, and any potential problems here?
Sir, pitfalls when we are placing the IPC, first of all, anesthesia should be complete, that the local should be completely infiltrated in the entry side, the exit side, the tunnel. It can be a completely painless procedure. The second thing, when you're placing the IPC, you need to place it completely inside the pleural cavity. The tip should disappear on the skin when you're suturing it and closing it. Otherwise, if the kink remains, the fluid will not drain, and you need to convert it into the open ICD procedure. Then the complications which you can expect after placing the IPC is like catheter related infections, cellulitis, then dislodgement of the catheter if it is not fixed correctly. And in Dr. Chavla's talk, he alluded that in the patients of malignancy who are on chemotherapy, who are suffering from cachexia, these patients, when you are placing the IPC and when you are observing them from time to time, the growing cachexia, the muscle loss, that increases the chances of dislodgement. So you can superimpose or make it sure that it does not dislodge by again suturing the IPCs and fixing them completely in the skin.
So I think these are important practical aspects which have been very well explained by Aditya. Thanks a lot for that, Aditya. One common question that comes up is whenever we talk about indwelling pleural catheters, then somebody will say, oh, it's complex, care has to be taken, and people are very well versed with the use of a pigtail catheter. So the question often comes, it's a pigtail catheter versus an indwelling pleural catheter, or and there are certain areas where even pigtails would be expensive in certain situations. So a smaller Malicot catheter instead of the IPC. So the ICD and the IPC has already been commented upon by Dennis, but I think we really need Dr. Rakesh Chawla's experience to tell us about his view about the pigtail catheter or a small Malicos catheter versus the indwelling pleural catheter. Dr. Chawla, your views on this, please. What are the advantages and disadvantages?
Mute.
See, when I was preparing this talk and when I was listening Vikas, yes, we are not reporting the data, we are not sharing the data. That is a very, very important aspect. I think the survey which came to my mind when I was preparing all this is going to help how many people across the country are really doing the IPC, and what suggestion has come from the people that multi-centric study. We can always, if we accumulated data of multi-centers of say 20 IPCs, it will be a huge data reported from the country. Since we are doing it 2016, 2017, COVID period, definitely you are not into this active involvement, but is a regular feature. Now the ICD and IPC, ICD with chemical fluorodecies and the IPC, plethora of data to support that IPC is superior to the ICD, a chemical fluorodecies in cases of recurrent malignant pleural effusions. If we go to the benign pleural effusions, or if you come to the debate of this, we are using since inception for years now the ICD for every case. Let it be a benign, it is an hepatorenal failure where you are facing the things, and you are using in malignant conditions everywhere. We were using the ICD. Came now the pigtail catheter. There are no head-to-head trials of pigtail catheter and IPC, pigtail catheter and ICD, because as the British guidelines have come, the size does not matter. In any of the effusion, the people started preferring the pigtail catheter. Pigtail being smaller in size, except in empyema where the fibrinous material will block this. Otherwise, the pigtail, even in studies where they have done head-on pigtail and ICD comparison, the pigtail have found to be superior, better in pleurodesis, and better in drainage, better in ambulation. So the literature is preferring pigtail over ICD. But if you compare ICD, pigtail, and IPC, there is no doubt with the robust evidence, the IPC scores over all of them.
So, Dr. Chawla, I won't let you go. Dr. Chawla, with your experience, what is the practical? Because I think, the many questions come up as far as the availability of the IPC, the familiarity of the IPC. Yes,
correct.
Yes, yes.
If you ask,
with the So yeah, just hold on. So let me finish. So let me finish. So that there are many questions that come up whenever we talk about IPC in terms of its availability, in terms of its knowledge about the technique, in terms of the care needs to be taken, and the ease of availability of the pigtail catheter. What I would like to ask you, sir, I know that there are no head-to-head trials, but sir, from a practical perspective, what message would you like to give our audience as far as decision making is concerned, about the pigtail versus the indwelling catheter?
See, if you ask me my personal experience when I was using, sir, there is ICD using everyone from A to Z. When we started using the small bore tubes of 20 and 24 for the pneumothorax, for the thin pleural effusion massive, we had no problems. Using 10, 12, 8 French, the pigtail catheters, there is no problem. The moment you are using the bigger pigtail catheter, the technique you are entering in, I don't know, literature supports or doesn't support the subcutaneous surgical emphysema incidence was quite high when I was using the pigtail of 14 French, which I personally experienced and stopped using pigtail of bigger diameter, which is the biggest 14 or 16, whatever is coming. But 8, 10, 12 were reasonably good in cases of pneumothorax. ICD, it is absolutely no issues. It is 20 bore or 24 bore. IPC, now as compared to the ICDs, is definitely much less in numbers. Since we started doing in 2016 and onward, specific indication when recommended, when you are not able to control malignant trapped lung. Yes, we had personally a good experience, and I shared with you even chronic renal failure data, which I was going through literature, is not shared. There are patients of chronic renal failure with hemorrhagic exudative fluid. Nephrologist will start upfront ATT, seeing the things that nothing is resolving. We can start ATT on therapeutic assessment. We suggested we can use IPC in these patients, and results have been good. Pleurodesis have been good, and that is not that prolonged to say 2 months or 3 months. We were able to remove it in 30, 32 days or 28 days. We were able to remove these catheters without convincing the nephrologist that ATT is not required, which most of the nephrologists across the board are using ATT on therapeutic assessment.
So I think thanks a lot. So that's what comes from an extremely experienced person who has experience of the entire spectrum of the techniques available over the years. Thanks a lot, Dr. Chawla. So to take this forward, I would like to ask Vikas, because how does IPC help in pleurodesis? Is it better than ICD or a pigtail? Are there any data on this? So clinical experience and data on this, please. Look forward, Vikas.
So if you look at mechanistically, when you put a foreign body inside the pleura, be it a ICD or a pigtail or a IPC, it basically causes inflammation. So in the case of IPC, these are not as rigid as the intercostal tubes. So it moves freely inside the pleura, so incites more inflammation. So more the movement, more the irritation of the pleura, higher the chances of pleurodesis. So possibly that is why the incidence of pleurodesis is probably talking about IPC would be more compared to the ICDs because they don't move freely. The second mechanistic cause is when you do an aspiration, when you're doing a therapeutic aspiration of these patients. So the process of the suction leads to the visceral and the parietal pleura coming close to each other, and that leads to a pleurodesis in these patients. So studies have shown, as I have discussed, the trials, our trial as well as the time to trial, all of them showed that if you do aggressive drainage, probably the apposition of the visceral and parietal pleura is much faster, which leads to higher rates of autopleurodesis. So it's the inflammation as well as the apposition. These are the two mechanisms, and the free movement of the catheter inside the pleura which leads to it. No, when you look at data, there are no head-to-head trials between a IPC or a pigtail. But most of these, if you look at the placebo arm where there was no pleurodesis done, the autopleurodesis was occurring, though at 50% the chances are there compared to when you do aggressive suction or you put a talc in these patients.
Yeah, so thanks a lot, Vikas. I think he's very well summarized this. And, the spontaneous pleurodesis has been initially was taken as a good, pleasant surprise. And then it has been seen, regularly and reported regularly in clinical practice as well as in the data. So now that we've discussed these aspects, I'd like to move to Renis. The question which is always asked is about intrapleural fibrinolytic therapy. So we know that intrapleural fibrinolytic therapy is used through the intercostal drainage tubes. So Renis, I would like to ask you, how would you do intrapleural fibrinolytic therapy via the IPC, and what are your preferred agents when you do this?
Yeah, my preferred agent will be always our streptokinase. What I will do is I will take one vial which may contain 7.5 lakh, and the stability will be around 24 hours. So I take 2.5 lakh from it, and then instill with the 40 ml normal saline. Dilute it and then instill into the through the IPC or pigtail or whatever, and then wait for 6 to 8 hours for the next dose. 2.5 again I will give the next shot, and then again after 8 hours I will just give the next shot of 2.5 lakhs. That way I will take care of the whole vial within 24 hours, and then I I see for the drainage, and I may continue it for next consecutively for 2 or 3 days. That's the way I go usually. And if there is some hypersensitivity reaction to streptokinase or contraindications to streptokinase, then only I will look into the other urokinase or 1 lakh urokinase or 10 milligram altiplase. But my experience with altipase and this alpha dornase or this urokinase is very, very minimal. So that's what I can say right now.
So for just for the sake of clarity for the audience, you said you can do it for 2 or 3 days. That means it would be one vial of 7.5 lakhs of streptokinase every day. So yeah, you could go up to 6 to 8, 9 sessions. Now, can you also add, how do you decide whether you are going to give only 1 week or just for the sake of clarity for the audience, whether when you stop at 1 day, when you stop at 2 days, and when do you continue for 3 days?
Yeah, what I will be looking, the output will be the drainage, first of all. And the second will be any complications to this streptokinase, which I am infiltrating. So if I see some blood tinge or some pain for the patient, I may stop. And if I see like the drainage is more and the daily drainage is more, I am getting with this streptokinase in loculated pleural efficiency, then I may continue for maximum 3 days. That's how I go about.
Great. So thanks a lot. I think that that's where we have a very good clarity and a very clear answer regarding the use of fibrolytic therapies. Now, one common issue that also one is also concerned and one needs to know is about yes, Dr. Chawla, yes.
I will like to reinforce for the benefit of the audience. People have read MIST 1 and MIST 2 trials. The foreign people have dismissed streptokinase totally, and they are stressing upon the agents which we don't have. But like me, there must be hundreds of pulmonologists across the country who have a wonderful experience with streptokinase as a fibrinolytic therapy, and patients respond what we are reading in MIST 2 or MIST 1 trials. So you please, I will definitely support. You can continue using with the available means at your end. This works, there is no doubt. Again, it will come that we are not able to report and send the data, show the drainage after STK, show the response after STK, our experience after STK. I think I am in favor of. I wanted to enforce it this way for Redis. Thank you.
So I think that's very good comment. That's from an experienced person. So, I would just like to take this a little bit further more now. A question that commonly comes up is in case there is there are septations in the pleural effusion, if there is some sort of a multiple loculi. So what would be the role of putting a indwelling pleural catheter and doing fibrinolysis? So, this is open to, the entire panel. Dr. Chawla, you would like to start on this?
Now, this is a very tricky situation. If it is an empyema, loculated empyema with fibrinous material, there is no need to get enthusiastic about doing a thoracoscopy that I can break these loculations, I can break these septations, I can place the ICD, or the ICD will move inside and will break the septa, will clear all this. It is not going to work. It's not going to happen even in a localized encysted fibrinous empyema. You use any amount of fibrinolytics are not going to work. This is a case which is, you say, stage 3 or stage 4 of organized fibrinous material. Empyema goes to the CTVS. It is stage 1 and stage 2 mild thin empyemas with septas, loculations. Yes, fibrinolytics work. You place an ICD, you place an IPC, because as Vikas said, the IPC catheter is lying freely into the pleural cavity. It keeps on moving, then it is not only creating the inflammatory reaction of the visceral pleura, it is moving and breaking the septas. If you see the videos originally of these septas, we talk as septas, there are the walls. These are not the walls. These are very thin fibrinous material which gets dislodged. And when you put in a the fibrinolytic agent, into the pleural cavity, it breaks and dissolves. So this is how I will take it and use of the fibrinolytics.
Yes, perfect. I think, one more thing that I would like to highlight here is the use of, yes, Vikas, please, Vikas.
If I may add, so the time since onset is
Yes.
also very important. So we've just concluded a randomized control trial where we've tried urokinase versus TPA. So what we found is that if the time of onset of the infection is less than 4 weeks, both work as well. So, and urokinase is as good as TPA, and after 4 weeks, possibly the TPA is a stronger agent. It works better, even though the chance of bleeding is slightly more. So loculation, the time since onset is very important because the collagen laying time is around 6 to 8 weeks. So after 6 weeks, nothing works. IPFT, if you have to give, it has to be early. So the history is very important in these patients. And first 4 weeks, all agents work as well.
Perfect. So I think that's yes, Renis. Yes.
I may even don't hesitate to call up an MDD and with my radiology colleague as well as my CTBS surgeon, and we sit together for the patient and then decide whom to tie the bell for the cat. So that way we'll benefit for a multidisciplinary discussion among who can involve in the case and do better for that patient.
Perfect. So I think that is the way I think, and often we are doing this multi-disciplinary discussion. Sometimes they're done formally, sometimes they're done informally. References are given. You call your colleagues, you talk to each other, and if possible, sometimes we also have to sit in front of the patient all together and discuss and take the appropriate decision. What is also important, I'd like to just emphasize again, is the role of ultrasound. Typically, we use ultrasound during the procedure, or rather just before the procedure. Make sure things might have changed. The utility of the ultrasound is to identify location, identify the sites of insertion, and also the characteristics of the fluid. So ultrasound is a fantastic tool, and typically I use it as a guide. I would do the ultrasound again, even after having given position to the patient, just to be sure that that things haven't moved and my site of insertion is secure. So good. We now move on to another common issue that is linked to the infections. I'd like to bring Anshu and Anshu. What are the risk of infections, and how do we tackle and prevent these infections post IPC insertion?
So there have been various studies done. A meta-analysis is putting the rates of infection of around between 4 to 5%, and local cellulitis rates of around about 7%. So yes, infections do happen. Interestingly, a lot of these infections are seen a few weeks after the insertion of the IPC and not immediately post-insertion. I guess some centers do practice giving some perioperative antibiotic therapy to the patients. That may also be the reason. Sometimes you do get worried that is there just colonization happening, or is there actually an infection in the IPC? In these situations, I think we have to look at the clinical features that the patient is presenting. If they are having new symptoms of fever, worsening breathlessness, or worsening cough, if there is leukocytosis on their CBC, we are seeing a rise in CRP or other infective markers. And we obviously, even if you do grow a positive culture, this has to be correlated with the other pleural fluid biomarkers. Like there should be a raised LDH along with the fall in glucose. Now, some will argue that malignancy patients can also have a low glucose and a raised LDH as part of the malignant diffusion. But most of these patients would have had some baseline pleural fluid reports done. And if there is a significant difference with the glucose levels much lower or the LDH levels much higher with a positive culture and the patient is symptomatic with features of infection, we should be considering this as an IPC related infection and treating it with antibiotics. The duration is generally 4 to 6 weeks. The good thing is that mortality because of these infections is very low. If you have a staph aureus related infection, the pleurodesis rates increase because it induces more inflation as well. And most of them do not require IPC removal. It's only when there is significant tunnel tract infection or there is significant empyema where you need to remove the IPC and then put in a chest drain to drain it.
Right. So I think that also covers a lot as far as the infections are concerned. sometimes the IPC catheters can break. I mean, there are reports on that. And I would like to bring Aditya into the discussion here. Aditya, what do you think? In case if there's a broken IPC, how does one tackle it?
Sir, the literature says you don't do anything if it has broken. If the silicon part is inside, you leave it inside. You don't try to dislodge it, or you don't try to remove the distal part. You just remove the proximal part and leave it as it is. The newer complications, there are some complications that the cuff remained inside, rest catheter came out. Then you need to break the fibrinous material and then remove the cuff, at least with the polyester cuff. Rest the silicon catheter, if it remains inside, no problems.
Good. So I think that's also a very good and a clear answer from Aditya. Dr. Chawla, Dr. Rakesh Chawla, I'd like to come to you again. What does one do if the IPC is blocked? How do you tackle it?
See, IPC, if it is blocked, the incidence is not very high. They say 10 to 13%. It gets blocked, but in my experience, since we have been using in the thin recurrent effusions and simple as we do ICD flushing with saline, it works. The simple saline and flushing of IPC does a good job. But if there is a fibrinous material at the anterior end, the foreign people have used atiplase, but I have, as I said, we are using streptokinase or urokinase in a little higher dose to resolve these mucus plugs, and they work to resolve. There is never been a need that we need to remove an IPC, but once it is desperate, it is not working, fluid is still there, on ultrasound fluid is coming, nothing is working like in ICD, we remove and again place. But if that ultimate problem comes that you have to remove IPC, which till now I did not came across, the literature says you remove it and place an ICD and drain the fluid.
Dr. Chawla, quickly, you mentioned streptokinase or urokinase. What do you use? Streptokinase or urokinase?
Streptokinase.
Yes.
Sir,
Okay,
sometimes,
yes.
Sir, sometimes the fibrinous material gets blocked inside the IPC. At that time, if you are able to catch hold of that material, you can manually remove it by revolving it around the gauge piece, and completely it comes out and the catheter works well.
Perfect. So all these are all practical tips. If somebody lands up into a problem, our faculty are just a phone call away in case you're in trouble. But I think after this discussion, I think a lot of the questions would have been taken care. Now, one common question that comes up is related to the cost of the IPC and the bottles. And already it has been discussed that, there is a solution for the bottles. Dr. Chawla referred to it. But, before we go on to the, I want to also go on there are many questions which are also there from the audience. Vikas, can you just tell us about the usual cost of the IPC bottles, and is there anything that can be done to bring the cost down? If you can just summarize that for us. Vikas, you're there?
Yeah.
Oh, we've lost Vikas. Yeah, you're there.
I'm audible? Yeah. So the cost of
Yes,
the
yes.
IPC catheter at present is around 35,000 rupees for the catheter. And upfront, I agree the cost is more, but then if it prevents the hospitalization, then it gets quite cost effective. And then during follow-up, you need bottles, which each vacuum bottle will cost around 2,000 rupees. And that will drain 1 liter of fluid. So these are proprietary products, and that is why the cost. And the cost of the catheter is essentially because of the proprietary one-way valve which these have. And that is the main, reason that the infection does not occur in these catheters. Now, looking at cost reduction, one is that you need not always drain it with the bottle. If the patient is coming to you for some other purpose, like many of these oncology patients come to the hospital for a PET scan, or they come for a blood investigation, or they come for a chemotherapy, you can easily use a suction. That's what we did in our study in the hybrid trial. So don't always use a bottle. The suction works very well, and the rates of pleurodesis is much higher because that causes apposition. So, you have to look at alternative things. One other way is like the bag, which Dr. Chawla alluded to. The next is there are some studies from West. We don't have much data from a country. There are studies from West, and I remember one from Dr. Vahidi, which was published in 2020, and he has done an incremental cost-effective ratio. So what they have shown is that in case the survival is good, so I'm a big fan of Lent score. You do a Lent score upfront and then decide which modality for which patient. So if the survival, say, possibly is 9 months or 10 months, so why not do a pleurodesis upfront? So if the catheter is not draining well, a very cost-effective way would be to put talc and do a fluorisis so that you can remove the catheter and reduce the cost of the consumables, that is the bottles. So it has to be on a case-by-case basis. So the most cost-effective is IPC plus, which is IPC with talc fluorisis, because it comes down the cost. And you can also do intermittent drainage via suction if the patient is coming for other reasons. So these are the ways, and aggressive drainage initially. So as I had shown in my study that, 35 days, we were able to reduce more than 50% of the catheters by a good aggressive drainage initially for any reason if they're coming to the hospital.
So that's very nice. I think Vikas has very well alluded, and I think taken this question very well. I'm going through all the questions which are there in the chat box. Several of them are already answered, and there's one question again. The cost of IPC is very high. What are the tricks to reduce the cost? I think the tricks of reducing the cost for the bags, they have been mentioned. They've been discussed. Also, to identify certain patients who might benefit if they got a good survival chance score, they might benefit. Then you could do a talc fluorisis. I want to come to Rennes. Rennes, for almost 2 decades now, you have been using an alternative procedure which serves like an IPC, but is far cheaper. Could you just tell us a little bit about this procedure and how do you do it and what's its average cost, the advantages, disadvantages? In short, just an overview about this. Over to you, Rennes.
Yeah, thank you, Dr. Prashant, for giving me a chance for coming up with my innovative way of doing in Indian scenario, especially for.
Can't hear you.
Yeah, Rennes.
We've
We've lost
lost him.
Rennes. Yeah, Dr. Chavla, yes.
Rural efficiency.
No, he's there. Yeah, he's there. Yeah. Please go ahead, Dr. Rennes.
May I chip in, Prashant?
Yes, sir.
I will add to the cost of the things. I do not know the price, maybe in the government.
Yes, Rennes. Yeah. And
Yeah,
then
sorry,
we take Dr. Chavla. Yes.
Hello, sir. Can you talk?
Yeah, please go ahead.
Yeah. I had a call in between, and in the next room we are having the executive meeting for NatCon, which is on the 2nd of Feb. So they are also coming in between. Sorry for that. What I was talking about was my innovative way of doing this aspiration of fluid was with aero catheter, single lumen aero catheter instead of a pigtail or IPC or an ICD. I use a single lumen aero catheter of size 14 or 16, which the technique is same as we do it for a central line in IJV or subclavian. With the Seldinger technique, with the guide wire, and then taking out, the guide wire, and then dilating it, and then introducing the single lumen aero catheter over the guide wire. So the technique is same. And you have a larger area there rather than going ahead with a vessel like internal jugular vein or subclavian vein. You have the whole pleural cavity in front of you, and you can have an ultrasound with you, and then see where to enter. Give a local over there, and then push in the aero catheter, just like the Seldinger technique as you do in a central line. And then you connect it with an extension cord of three-way extension cord. So that you can close all the levels, and then the patient, and you can stitch that aero catheter onto just you do it over the neck. You can stitch it over the thorax, and then the patient can roam around, and it's like a tap water. You can drain it out, but whatever you like. It's a controlled way of doing or draining out the fluid. You can go up to 1 or 2 liters on a day, and if the patient coughs or you feel like some complication is occurring, you can stop. Or always it should be underwater seal with an what you call it, you connect it to a IV drain, and then it should be underwater into a bottle, and it should be underwater. And that only to be monitored and taught to your nursing staff if you are doing it at some other place. I was practicing the patient whenever they feel like to stop it, you can disconnect the IV line from the three-way and then give the stopper and let him move around. no issues. And usually I do it for IP patients, and usually the hospital stay is less because I can make it less, faster or slower. Depending on how the drainage. It's like I told you, opening up a tap and closing a tap whenever I feel like, and whenever the patient feel like. And I've not come across much complications. So the only complications you can say is some kink sometimes, or sometimes block. Those blocks will go off with just flushing the saline into it. And even you can do the pleurodesis whenever you feel like, whenever when the drain is less than 150 over 48 hours, I usually do pleurodesis. If the lung has expanded, you can confirm it from an X-ray. And I do it for most of the malignant pleural effusions. And I feel it, I'm comfortable for the last 2 decades. And I have a publication, I don't remember which journal I've given it, around 10, 15 years back. But still now, touch the wood, I have not come across major complications. So I am comfortable with this, and cost will come only around 2,000, and plus the procedure charge, whatever you feel like, not more than 3,000 or 4,000. That's what I feel. I think for Indian scenario, we can have this kind of innovative indigenous method to drain the fluid if it's getting benefit for the patient.
Great, great. Thanks a lot, Dennis, for this. I think, these are the various adaptations which one does based on the scenario, clinical practice and experience. And what would really be important is that, we get data on these matters, or on these experiences, and publish it so that this experience is available in a systematic way to the to our peers at large. Dr. Chawla, we're running out of time. Last, you raised your hand. Your comment, please.
See, the cost you can bring down if you want to use your original IPC catheter. The cost is 22 to 24,000 rupees. Upfront, you are not buying the bottle. You can save the money. Use Eurobag. Very simple. There is no issues. One way, it fills up. Take it out and throw it. You just use another Eurobag whenever patient comes back, or he uses at home. 1. 2, you can use the Romo drain, as Vikas said, double bottle arrangement. We use in BPF cases where lung is not able to expand, the fistula is bigger in size. You are attaching that double vacuum bottles of remote drain with the suction, and you have the slow suction machine, the small available. You switch on to the slow suction, the lung gets expand. 3, as he said, you can do on the spot DCIS. DCIS is when visceral and parietal pleura are opposing each other. At any given time, if you have placed an IPC and the lung has expanded, at any given time, the pleural cavity is vacant after you have done the drainage. Do the pleurodesis at that time. What IPC plus is going to make a difference. And once DCIS is successful, maybe another day or 2, the drainage is reduced, check it with the ultrasound and remove the IPC. Or you can do it same with the ICD also. When lung has opposed, you do a pleurodesis, because at least pleural cavity is vacant at that time when the fluid has gone. So there is no need to change the original catheter. And 4th, after this webinar, I am going to talk to the owner of Hansraj Nayyar that take this and make Indian silicone catheters same thing, because I'm sure 1994 the patent of these must have gone, and Indians can manufacture same quality silicone, same catheter, same the tunneling catheter and the same kit at a much cheaper price. Why should we go to the jugaad of innovation? Better to motivate these people and make a better copy of the original and serve us. Thank you.
Great, great. Thanks a lot. I think we can keep on discussing and discussing, because there's such a wealth of knowledge that we are getting from the speakers and panelists. I have done my best to cover as many questions as possible from the chat box as well. I'm sorry if about it, because we've run out of time. We are at now 10:30 p.m. We need to sign off, and I really want to thank Dr. Amita Nene, Dr. Mehul, the IAB organizers, and the entire speaker and panel faculty who have made this entire seminar or webinar such a wealth of learning. So thanks a lot, Dr. Chawla. Thanks a lot to Vikas. Thanks, Renis. Thanks, Anshu, and thanks, Aditya. And thanks to the entire Sepla team and the connectivity team for this seamless presentation. With that, thank you very much and wish you all again a very happy Republic Day.
Thank you.
Jai Hind.
Thank you. Thanks.
Jai Hind.
A wonderful moderation as well.
Happy
So,